Here, the one right down the road here in Uvalde, they were operating for a while just on daytime and being able to meet the needs of the population. And now they're operating around the clock and 7 days a week too. And probably will have to add another facility in fire. So that tells you there are many patients in our area in renal failure. Now, we talked just briefly about in fact, the diabetics, right now, 80% of people that are type 1 and or type 2 diabetes have diabetes. 80% of those people will end up in renal failure. That's high. That's why we have so many. That's why we have Fresenius, who is the big company that makes the machines. They're multi-billionaires. They have to be, because all of these dialysis center in these towns, most all of them are owned by Fresenius. And so it's a major company that has developed the dialysis machine that seems to be the most popularly used as far as renal dialysis is concerned, and hemodialysis is what I should say. Certainly you can do peritoneal dialysis, and some people do that and are maintained at home by their family. And it's a different process, but at any rate, they still get their solutions and everything from Fresenius that they have to use. So it is a major problem, and it is a complication of diabetes, categorized as a complication for diabetes. And the bottom line is that the high sugar levels are destroying the glomerulus, and there's only a finite number of glomerulus in every patient. And so when they're destroyed, then they either have to be on dialysis or be on the list for kidney transplants. And the good thing is, of course, that if a family member is a match, then the family member still has one kidney left and they can share another kidney. And donors are doing that. There's no question. The best way to get a kidney is from a cadaver. And I don't know, as young as you are, you probably haven't thought about whether or not you choose to donate any of your organs, but it can be very, very helpful, certainly to someone else who is waiting for a kidney and right now is on dialysis, which takes a huge amount of time out of their life. And just give it some thought. I don't know the percentage of people in this area, and I can look it up, but I just have not, that really identify themselves as organ donors for Southwest Texas. I have no idea what the percentage is, but that might be something that you all would want to look at, and some way of serving other patients and maybe yourself on down the road as to being able to benefit, especially in the event of accidents. And you can't turn on the TV in San Antonio for what there hasn't been a fatal accident every day. And so if even 50% of those people were organ donors, look at the number of people that could benefit from that. So if you haven't considered it, it's something you probably should. And because once you're gone, you don't really need them, do you? No, absolutely not. Okay. So let us go through our routine here for renal. When you were reading your material, was there anything that you had difficulty understanding that we could talk about first? So you understood everything, so I can just stop and give you the test and we'll go on, right? Is that accurate? No questions at all? Well, can I ask you one then? As far as some of the lab data, and that's important. Most people are familiar with the blood urea nitrogen, the BUN. Doesn't tell you a whole lot, but it's one of the tests that they run. What is the test that really tells a physician the most about renal function?
GFR.
GFR, okay. And the glomerular filtration rate is very important. Then, prior to some changes in that, they're going to be looking for the difference between creatinine and creatinine clearance, right? So what does the creatinine test really, what type of information does it really give? Anybody in Del Rio? Well, let's take it back to the ladies in the room. For those that have had children, your renal function was followed to some degree for your prenatal care, right? Do you remember that? Okay. So the obstetrician or your family practice physician, whoever was following you, was looking to see if what was being excreted by the kidneys. Protein, very good. Okay.
Mhm.
So there's a normal amount of protein though that would be excreted, would it not? Because you eat protein, and so therefore the breakdown would be there. So the creatinine level, the serum creatinine, though, is measuring what type of protein in the body. Muscles, because you have muscle wasting, don't you? When you exercise, you actually are releasing the protein because some of your muscle is being destroyed, and therefore it's measuring that level to see if in fact the kidneys are able to get rid of that protein that's being broken down from muscle activity. Now, you do eat protein, so is that included in the creatinine test, the serum creatinine? No? Okay, what's the name of the test then that addresses that? Anybody? Well, to some degree the BUN, but you're looking at the creatinine clearance to see whether or not you're actually then clearing the amino acids that are being metabolized from your protein, that you consume. So there are two different phases of this, okay? And so it's important that you know that. Now, the BUN is really the nitrogen component that is being evaluated, and it does give a reflection of the protein metabolism, but for the most part, the the creatinine and creatinine clearance are much more accurate tests, but the most accurate that everybody wants to be sure that is okay is your glomerular filtration rate, which tells the physician that, number one, you have enough in the way of fluids to allow the glomeruli to work adequately. And so it's important that you do take in your 2,000, a minimum of 2,000 milliliters, which is 2 quarts of fluid each day, in order to help facilitate glomerular filtration, which is affected by your flow rate, right? By your arteries, the renal arteries that supply the kidney to begin with. So those are things to remember on your own as to whether or not you have good renal function. Certainly the kidneys maintain a balance between what's taken in and what's removed. And then at the same time, because everything that you consume or take in the way of medications metabolize. And it's those metabolic waste products that are also important because they can be destructive. Some of the nutrients are conserved because, for example, the electrolytes are reabsorbed in the loop of Henle, and so that would be important. And then also it regulates the acid base. It is a slower regulatory mechanism than respiration. So the respiratory rate, when you have altered, if you in fact, the patient is starting to be acidic, then the respiratory rate will change. But also, then the hydrogen ion distribution will be altered in the kidneys. Most people have paired organs, one on each side, but they may have a horseshoe kidney. And there are people that, for whatever reason, when during the developmental stage, the edges of the two kidneys fuse together to where it really looks like a horseshoe. And unless the patient has x-rays, CAT scan, well, primarily an MRI, they may not actually know that. And they may have very adequate urine function and never had difficulty until maybe they decide to be a donor. And lo and behold, then they find out this person only has one continuous kidney instead of 2. So that does happen. The right kidney is slightly lower than the left because of the displacement from the liver. And as far as having the fact that this is an issue, it really is not. And you will see some of this in some of the diagrams, that the right kidney is just a tad lower than the other because of the space that the liver is really taking up. I started to tell you, and then I got sidetracked with the test. I've given you both 3 sets of PowerPoints, and I also added some PowerPoints that the director who was at Uvalde Memorial Hospital put together. And Ed was really a nut about finding pictures of diseased organs. And so what he did was find a whole bunch of pictures as to what kidneys look like whenever the individual has, let's say, kidney stones, and they end up with a hydronephrotic kidney, and what pyelonephritis looks like, et cetera, et cetera. So I would suggest that you scan through those PowerPoints so that you can see really good pictures of what a diseased kidney looks like, okay? You might find some help on the test, but for the most part, I gave those to you so you could really get a picture of what the kidney looks like that is no longer functioning appropriately. So there's a few in your textbook, but not a lot. I have a couple of them here, but anyway. The kidneys are located retroperitoneal toward the back, as you all well know. It's outside of the peritoneal cavity. And there is a capsule that it's a really tight membrane that wraps around the kidney. And what happens sometimes with a compression type injury, such as an MVI or motor vehicle accident, the kidney may be damaged and actually bleed into that capsule, but it may not be found right away, and the capsule may stay intact if it's not severe, but the capsule is a protective mechanism. And then also the kidney is pretty much surrounded by fat in most average sized individuals. In other words, people that have an average weight for their height, just like some of the fat around the outside of the heart, the kidney also has some of that. The hilum is the inner part of it where all the important mechanisms go in, and the hilum is in this area right here where you see the veins and the arteries and the ureter, etc. So it's fairly straightforward. It does have some endocrine function in that it secretes renin. We talked about erythropoietin in that if the carotids sense that the hemoglobin is low, then it will start producing your erythropoietin. This is the hormone that actually has to do with both erythrocyte production as well as calcium metabolism. And the vitamin D is the vitamin that is responsible, or it assists and provides the mechanism for the parathyroids to control calcium in the body, and they all work together. We know that many of our foods are fortified with vitamin D, right? What's the most common one that you see? You probably drink it for breakfast. Milk. Milk, okay. It doesn't come from the cow fortified, but it is pasteurized. And so that helps. And of course, we also have the experience of getting vitamin D from the sun. But on these cloudy days that we've been having recently, there's not much of an opportunity for that. So the structures of the kidney are well described here, and what they're responsible for. The glomeruli are the major functioning constituent of the kidney and produces the urine, which then flows down into the pelvis and then eventually goes down to the ureter, to the bladder, where it's stored until it's empty. So this is a picture of the cortex, the outer side of the kidney itself, and then the medullary pyramids that contain a bunch of glomeruli that all work together, and as the urine is produced, then it flows down into the structures here and move on down into the bladder. So this is referred to as the renal pelvis here. And then the hilum is where all of the vessels go into the kidney, because the structure is just as you see it. There's nothing that enters on the outside of the kidney. It all goes into this middle structure here, and the renal artery and the veins, etc. They go into the kidney here. And there's another picture that shows that. And it's in your book also, so not anything you haven't seen before. The nephron is a functioning unit of the kidney and comprise the activity of the glomerulus. And so we have on the average of 1.2 million nephrons per kidney, and that is the functional unit together of the kidney itself. And we lose those as we go along. None of this should be new to you. The glomerulus is really the filtering unit, and that's what they try to mimic in the patients that are on dialysis, so that you actually have activity that goes on in the glomerulus, and then the other area, and that's well defined in your book, is your loop of Henle as to what really goes on between the time that constituents are filtered in the glomerulus, and then some of that is reabsorbed as it's needed, and it goes back into the bloodstream in order to support the cardiac output. You know, that's basically what it does. And these are some breakdowns here of the structure and how the vascular system really connects with the glomerulus and the Bowman's capsule, etc. There's, yeah, this is not the one. As we go along here, we'll talk. There's a diagram that will help you to see where water is reabsorbed and where sodium is reabsorbed and potassium, etc. All of this you should have had before, and should be familiar with what's going on with the blood vessels and the problems that people may have if they are experiencing renal failure. The ureters are 30 centimeters long, and they're held sort of in place by some of the muscular activity. And it's important to know that if there's a stone in the ureter, and if the stone isn't moving, the patient will probably not experience much in the way of pain, maybe more in the way of aching. But once that stone starts moving down the ureter, then the referred pain may be described right around the umbilicus. And that is something that's important for the nurses to know. So the individual may have more pain in the front around the umbilicus than they actually have in the back, in the lower part of the rib cage. It just depends on where the stone is originating from. So if it's down in the ureter and traveling large enough that it's causing pain as it descends, then that the patient will be bewildered with the fact that they have pain around their belly button because they haven't had that before, right? And the other area where stones may have some referred pain is when they get down closer to the bladder. Then the pain may be in the medial part of the thigh. And again, that's deceiving because it's like a muscular contraction in the thigh muscles. And that's what it causes, when in fact it's really a stone that is descending through the tubule. Let me go back here. Have you ever heard of people having trigonitis? Is that term familiar with you at all? Have you ever read that? Some of you that are LVNs or RNs? I'm trying to find a picture here. You have here the ureters coming in on each side of the bladder. And the trigon is really the triangle from across the top where the ureters enter the bladder, and then down in the base of the where it goes through. This is a male, and it has a prostate gland, obviously, and so then it moves on down. But when people are having difficulty with foods that they're consuming that are irritating to the bladder, this is usually the area right here that becomes very, very inflamed and is really causing the symptoms that the patient is having, which will be frequency, urgency, pain usually at the last part of when the bladder is empty, and that's what people refer to as trigonitis. Also, the nerve endings that tell you when you need to go to the bathroom, when you need to empty your bladder, is in the lower part of the bladder here, again, in the trigon area, okay? So that's when, for people that begin to lose some of the bladder control, they may do fine when they're lying down and not having any sensation that they have to go to the bathroom. But the minute they get up, they have very strong sensation because the weight of the urine in the bladder sends stimulus forward that they have to empty. And many times, because of their poor control, their poor muscular control, they will empty their bladder when they first stand up. And that can happen both in a male patient and a female patient. And it's because of that sensation that they have missed somewhere along the way when their bladder is filling. But when they stand up, then as the urine puts pressure in the lower part of the bladder, then they get the sensation, oh, I've got to go to the bathroom. They can't get there in time. So that's not unusual, especially for some of the older people. Or for women who have had large babies, have delivered vaginally, and have maybe put a lot of pressure on the lower part of the bladder. So they get some different sensations than when they, before they had children. Any questions about that? There are many types of foods, and especially a lot of the drinks that we have that have a lot of carbonated water. That can be very interesting and be one of the things that people have to determine what is really causing the bladder irritation. And certainly, the physicians can prescribe medications that will help to decrease some of that urgency and frequency and pain that people have when they have an inflamed bladder. But you need to find out, why is it becoming inflamed? What's causing it? And so what has to happen is, if they think that it has to do with the diet, then they'll put people just on almost no food for a day or two to get away from everything that they're eating. And then they add a few components each day to see when the symptoms return. And that's how they figure out what the problem is. It could be fruits, it could be certain vegetables, or it could be something that people are actually drinking. And sodas have certainly risen to the top of the problems that precipitate cystitis, which is what the inflammation is referred to as, and causes major problems. So the trigonitis, if a patient has trigonitis, that means that the lower part, right here, of their bladder is very inflamed, and it can descend into the urethra, and it does, and therefore then the symptom occurs at the beginning of when they're starting to release the urine, and also at the end, whenever remember the urethra and the ureter both have some muscular activity that goes on to propel the urine down to the bladder as well as outward. So it's important to know those things. Some data here that is in your book, and as to the length, etc. And then this to me is interesting. The kidneys receive 1,000 to 1,200 milliliters of blood per minute. So the vascular system for the kidneys is really, really, really important. When patients come in and are some really acute problems, let's say they're a code situation, and due primarily to heart conditions, it's very, very possible that they will go into acute renal failure, which means that the kidneys are not functioning for a period of time. And the good thing is that many of these will recover slowly once the condition with the heart is corrected and the blood flow to the kidneys is returning to normal. Then many times they will begin to produce more urine, and it will be normal urine. In other words, it won't just be like water for the people that are on what we call high output urine failure. For people that when you have a Foley catheter in patients in the hospital and you look at the urine in their Foley bag, and it's just as clear as it can be, these people have very few particles in the urine. And so what they're doing is getting rid of the fluid and not really getting rid of the components, the metabolites, et cetera, that they need to be getting rid of, which means it's building up in the kidney, in the circulation, I'm sorry. So the glomerular filtration rate, the reason why it's important is because it truly is related to the perfusion pressure in the capillaries, which of course has to do with the blood pressure itself. So all of that is really very much tied together. The regulation of the blood flow is pretty automatic, and even though you have patients coming to the ER and their blood pressure may be low, their mean arterial pressure may be below 60 or right at 60, but lo and behold, for a period of time, there is an automatic regulation to the amount of blood that actually is flowing in through the kidney in order to keep it functional for a while. So when people say, well, if this patient has a decrease in urine output, then we get excited. Well, the change is actually occurring prior to that. But because of the autoregulation and the ability to pull more blood in from the aorta for a period of time, it does, the kidneys will not reflect it in the output right away. The amount then of urine output should be anywhere from 40 to 50 cc's if people are getting enough fluid, and then that will decrease over time. Patients that you'll see when they come back from OR, while they're in OR, they're given a lot of fluid in order to keep their blood pressure up. So when they first come back to the recovery room and to the med-surg unit, the urine will be very pale because they have had a lot of fluid in the OR. Well, that's an okay thing, but what you really have to observe then is what happens when the patient is about 10 to 12 hours out of OR. Then what happens to urine output? That will be much more reflective of the patient's true response, because when they first come out of the OR suite, they're going to be dumping all that fluid out that has been given to them in the OR in order to keep the blood pressure and the cardiac output up. Does that make sense? Okay. Any questions about that? You'll see it. You'll see when patients come out of, if you've taken care of them before they go to OR, you will see that around their eyes, they didn't have a lot of swelling, but when they come back from OR, you will see that this indentation here will be gone, and they'll have really puffy eyelids, and their fingers will look like little sausages in their toes, and they'll have swelling around the ankles. But if they have good kidney function, within the first at least 12 hours, they'll dump a lot of it out. You'll see that. And then what comes after that is what you actually watch. Most surgeons write the order, to do hourly outputs on their patients, especially if they have a concern that their filtration rate prior to surgery was not what it should be. So they'll want to see how quickly the patient is able to get rid of all the fluid that they've been given in the OR, and then what happens afterwards. So it is important, and it's important for us to identify a time that we're dumping their container to see, how much they put out in an hour. You don't want to do it on the hour one time and 30 minutes later another time. So you've got to keep that consistent, because it really is important, and it does tell the patient or the doctor what's going on. Again, our sympathetic nervous system controls the renal function for the most part. We know about vasoconstriction and vasodilatation, and certainly the arteries that go into the kidney, that's controlled. The major fluid balance has to do with water and sodium balance. And that is then identified through the osmolality and osmolarity. That is controlled.
Yeah, there's no inhaling
with one factor for the antidiuretic hormone, or ADH, which slows down the amount of urine output to decrease the amount of diuresis. And then it was very interesting. The reason that I was a little late coming in, I was working with a BSN student that had a patient that he was following, and so we were going over some of the issues. The patient had a long diagnosis of heart failure, CHF, congestive heart failure. And it was interesting that his belief was that he didn't need to worry about his salt intake, because he believed in holistic medicine, not necessarily the drugs the doctor was giving him, because he didn't take them. He was non-compliant with those. And he came in with the medicine that he was on did not have anything to do with his renin-angiotensin aldosterone level. It was just simply a diuretic, but he wasn't taking that either. And so he was really doing his own thing. But his what is one? Just a minute. I'm having a blank here. Anyway, the test that shows that he truly is in heart failure was extremely high, higher than it's ever been. So his holistic medicine wasn't working very well. And he had a lot of peripheral edema in his hands and in his arms, his legs, dependent edema. And so he needed some medications. He really wanted to stay in the hospital when the nurse practitioner said it was time for him to go home, but he didn't need to be in the hospital anymore. Then he came up with all kinds of excuses. So what happens with patients that have other problems, and obviously his heart, his pump was the primary problem, because he was in congestive failure, but it was affecting his kidneys at the same time. And it's like a succession of things that occur when people go into multi-system organ failure, that the weakest organ begins to fail first, and then the others will follow, especially if they're not controlling or taking their medications, or if they believe that their body's going to take care of itself. Well, it will, I guess, to some degree. But anyway, it was very interesting to hear some of the beliefs and some of the problems that he had with. We've talked about this. The urea that can be measured, the BUN, the blood urea nitrogen, And urea, of course, is really the end product of a lot of metabolism. And so it's true that the BUN is a reflection of that. And for the most part, the docs will order a creatinine level and instead of a creatinine clearance, because they're more concerned about what the destruction is as far as the muscles in the individual, and then are the kidneys able then to retain the protein when it's needed or to get rid of it, and so that's important. So for the most part, what we have is the process, first of all, is filtration, and it moves across the glomerular membrane, and it does affect the hydrostatic pressure. And then you have the reabsorption in the glucokinase, and the fluids and the electrolytes that are moving through the glucokinase may be released in the urine, or it may be reabsorbed because it's needed by the body, and that's why we have sensors. And so then you have your tubular secretions, and then of course your excretion. So this is the process of your kidney function. The major electrolytes certainly are your potassium and your sodium, along with chloride. So the first thing that you look at when you get your electrolyte panel is where is the potassium level, where is the sodium level, and sodium and chloride combine at some point in time to be released, and so these electrolytes really control many things in the body. I'm missing something. Just a minute. Oh, here it is. Here we have the glomerular filtration and what is actually lost in the urine, but the one that I like better is this one right here. It really straightens out the leukokinase. Here you have your glomerulus and your bone capsule, and then it filters the blood, and it goes into the proximal tubule, the leukokinase, and the distal tube. And this then right here tells you what is being reabsorbed in the distal tubule. Your sodium chloride can reabsorb water, bicarb, and then of course your electrolytes. So when you look at the tube as it is straightened out, then it kind of demonstrates a little bit different picture to you as to where the water and or the electrolytes may be reabsorbed if they're needed by the body itself. If the sensors indicate that the blood is in normal condition and everything is working well, then it will excrete it into the bladder and you'll be rid of it. So I don't know if you see this is helpful to yourself, but you can remember this slide right here because it's easier to deal with than trying to figure out what's happening in the loops here. This one gives you some information. I think this is directly from the book also, and it shows where in the vascular space the sodium and the water is going into the blood vessel themselves. And typically, where water goes, sodium goes. So if you have someone that has been drinking a lot of water and they have obviously then a large urine output, you have to understand that their electrolytes are going to be off, especially their sodium. And usually where sodium goes, potassium will fall. So you will have a decrease in sodium and potassium for a patient that is getting rid of a lot of fluid. And of course, patients will get rid of fluid after they've taken their diuretic. So the diuretic just wrings everything out to get rid of the fluid. And now they're understanding that for hypertension, the medications that control the amount of renin being secreted and aldosterone and what's the other one? Aldosterone and angiotensin. That is a much better way of controlling the blood pressure than wringing the fluid out of the body. So, for the most part, the internal medicine people don't use as much in the way of diuretics as they have in the past. Now that they have new antihypertensive drugs on the market that control the amount of renin and then the production of your angiotensin from the lungs. So that's how they actually work, rather than just getting rid of the fluid. Because when you get rid of fluid, you're also getting rid of potassium, which is vitally important, and you're getting rid of sodium that the body needs. And so that isn't always the ideal way of managing high blood pressure. Concentration of fluid, we've kind of gone over that already. I don't know if there's anything else here. As the antidiuretic hormone controls the concentration of the final urine. So it really, the ADH plays a role with the distal tubule as to what is reabsorbed to go back into the bloodstream. The BNP is what I was trying to think of earlier. The BNP that is ordered on people that come in, like Scott's patient that he was taking care of, the natriuretic peptide is a reflection of the severity of congestive heart failure. And when it was first recognized, it was named brain natriuretic peptide, but it really is one of the peptides that is secreted in the ventricles, not necessarily the brain. So it's a misnomer. And be aware of the fact that the people that come in congestive failure, one of the first lab data that the physician will order will be a BNP. And the BNP stands for brain natriuretic peptide. But it really is a peptide of a protein that is coming from the cardiac ventricles. Because that then will reflect the quality of the ability of the heart. Doesn't make sense, does it? But that's the way it is. So you kind of remember that as you go along. I didn't name it, somebody else did. So vitamin D, we've talked a little bit about, and the fact that it's important to be sure that you get enough vitamin D to control and to have an influence on the calcium. Also has to do with cholesterol and the skin, etc. And so in order for the parathyroid hormones to be produced, you have to have a certain amount of vitamin D. And probably people that are active and outside do get enough vitamin D. But I think if you were to do a survey of the patients coming in the hospital that are over 60 years of age, you would find that most of them are actually on a supplement of vitamin D that can be purchased over the counter. So it's not an expensive medication to take, but it certainly does have to do with the overall activity of the calcium distribution in the blood, in the body. And of course, older patients tend to break down the bones more readily, so therefore they need adequate calcium to be retained in the bones in order so that they don't have, when they bump something, they don't break. Erythropoietin, and we talked about this some time ago, in the developing embryo, it's produced by the fetal liver, and then later in the adult kidney. And this is essential for the production of red blood cells, but now it can be given to patients in order to stimulate. If there's any kidney function left, then erythropoietin will attempt to stimulate that. And it will enhance the rate at which it produces erythropoietin. And we talked some time ago about the fact that people that do not take blood replacement products because of their religion, etc., they can take larger amounts of erythropoietin in order to try to stimulate the bone marrow to produce more of the red blood cells than the average person. So that's one way of treating the patient. The creatinine, we talked about that, and the serum creatinine, the BUN. It's easy to remember as far as the normal amount is 10 to 20 milligrams per deciliter. And if the individual has not been drinking because of dehydration, or maybe they're having a bout of vomiting and diarrhea, then that will certainly be reflected in the BUN, and it will go up. For people that are moving into chronic renal failure, it will be reflected with a consistent rise in the BUN. So it's important for the physicians to know that the individual is actually taking in adequate fluid because their lab data will not reflect that they are. And so it's good to keep track of that. The serum creatinine, this is the normal 0.7 to 1.2 milligrams per deciliter. And this generally gives information about how the kidneys are functioning and whether or not they're actually able to get rid of the protein. And here, if the GFR is doubled, then renal function is half of normal. If it's tripled, then 75% of the renal function is lost. So that's criteria that's used to see what's happening. But obviously, we want the patient to be within 0.7 to 1.2 milligrams per deciliter in order to reflect the fact that they have normal glomerular filtration rate. So this is what you look for in the urinalysis. Does it have adequate color to reflect that there's something there besides just water? Certainly the pH, the specific gravity, and then you would not expect to see RBCs past crystals and WBCs in a normal urine output. There might be a few RBCs that are measured, but for the most part, that should be none. And you do have dipsticks. They're not used as much as they used to be because now all of the urine and the only thing that nurses actually do at the bedside will be the glucose levels for patients that are type 1 and or type 2 diabetics. So we don't use the urine dipsticks as much anymore as they used to, but I think they're even available in the hospital on the units. For the aged, you have a decrease in kidney size. There will be a decrease in the RBF, the renal blood flow. And of course, when that begins to occur, then always and definitely they'll have a change in the filtration rate because the filtration rate is dependent upon the renal blood flow. The number of nephrons will decrease because they're tired and worn out and have been damaged by various and sundry things. Remember that we talked about the breakdown of muscle and how to differentiate blood in the urine from muscle in the muscle cells in the urine. And we have to remember, and this is incredibly important, that people who have had muscle damage, and that includes people that are being coded, if they're shocked, they're going to have muscle damage. Okay? Right? If not, we'll try shocking you and see if you think you have muscle damage after it's over. It hurts, and the muscles are damaged. So after a patient has coded, it's incredibly important, and you'll see the docs order an increase of fluid rate in order to get rid of the myoglobin that will be circulating. Those muscle cells that are broken down, they will be in particle form, circulating in the blood, and if those particles are not gotten rid of through the urine as quickly as possible, they will settle in the glomerulus and destroy the glomerulus. So muscle tissue, fragments of muscle tissue will cause kidney damage and ultimately kidney failure in a patient that has poor kidney function to begin with. So it's important that you have people, if they can drink fluids, then push the plain old water. If they can't, then the docs will order an IV for a period of time until the fragments of muscle will be gone. People that come into the ER that have been in accidents and maybe had crush injuries to, let's say, their thighs, they're going to have a lot of muscle breakdown. And so these are folks then that you have to be extremely careful with and be sure that they're getting enough fluid to flush out the muscle fragments so they don't like limit in the glomerulus and destroy them, because they will. So we already know that. We talked about bladder symptoms, the urgency, frequency, and the nocturia. The capillaries in the glomerulus will atrophy with age, and also the patients that come to you to the ER from nursing home, many times they are poor fluid intake patients, and maybe they have had catheters inserted for a long period of time, which gives a direct ascending potential for bacteria to get to the kidneys. And so it is important that we, if patients have catheters in, be sure that they are getting enough fluid to help them get rid of any of the bacteria that may be forward. So let's take a break and we'll look at some of the abnormalities.
Ready?
I'm going to take a quick break. I'm in the middle of class right now, so I got to take a quick break. But I'll be back on.